Hello, our guest today is Professor Kevin Fenton, CBE, PhD, FFPH and FRCP. Professor Fenton is an internationally recognised public health leader and infectious disease epidemiologist with extensive executive experience across government, academia and global institutions. He shaped national and international policy on health improvement, health protection and the reduction of inequalities, and played a pivotal role in London's response to the COVID-19 pandemic. He was appointed Commander of the Order of the British Empire in 2022 in the New Year's Honours for his services to public health. Since April 2020, Professor Fenton has served as Regional Director of Public Health for London, initially with Public Health England and since October 2021 within the Department of Health and Social Care and NHS London. In this capacity, he's also Statutory Public Health Advisor to the Mayor of London, the Greater London Authority and the London Assembly. He leads London-wide strategies to improve health and well-being, prevent disease, protect health and tackle health inequalities. He was President of the UK Faculty of Public Health between 2022 and 25 and President of the British Science Association 24 to 25. In December 2021, he was appointed Chief Advisor on HIV to the UK Government and Chair of the HIV Action Plan Implementation Steering Group, overseeing delivery of England's national HIV strategy. In 2020, the Power List named him the second most influential Black person in Britain for his leadership during the COVID-19 pandemic and his groundbreaking work on inequalities. And also in that year, he directed the National PHE Review on Disparities in COVID-19 Risks and Outcomes, culminating in the landmark Beyond the Data report, which inspired our programme. Its recommendations have shaped more equitable pandemic responses across the UK. So that's quite some bio, Kevin.
I know, it's probably too long.
It all started with being born in Glasgow.
That's right, yeah. I was born in Glasgow and my mum at the time was studying her midwifery postgraduate degree. And at that time, nurses from the Caribbean would study in the UK and then return to the Caribbean. I happened to be born here, spent my first 2 years of life in Glasgow and then returned to Jamaica. And I left Jamaica after medical school, did a couple of 3 years of working in the Jamaican Health Service prior to returning to the UK, and then decided to continue my professional journey and my personal life journey here in the UK. But as you've said, I've had the privilege of working and serving in different continents on a range of public health programs over my career. So it's been a fascinating journey and a fulfilling journey as well, both personally and professionally.
So that range of different perspectives from the different countries, the different continents, different cultures, must give you a very interesting view of public health and the way that things are done in different places. How does that inform your practice?
I think it's everything that I do today is a accumulation of all the experiences that I've had. I decided to do public health because, and I tell this story often, that I grew up in a family, my mum was a nurse, my father was a teacher, so that sense of service was also always instilled in us. And being in the Caribbean in the 70s, as a child, you were expected to be a lawyer, an engineer, or a doctor. You had to choose one of the above. And my decision to choose medicine was obviously because of that early exposure to health through my mum. But my decision to do public health was shaped by, first, the emergence of the HIV pandemic in the early 80s, which I think really brought infectious diseases, stigma, discrimination to the forefront, fear of an infectious disease to the forefront of young people and people at that time in the early 80s. And then secondly, in medical school, understanding that you could actually be involved in medicine and health and not only be limited to treating one patient at a time, and the possibility of improving the health of communities, of societies, of global populations, and how that was actually done was one of the big eye-openers for me in medical school and really got me interested in public health. So I think that journey of my personal lived experiences at home, my orientation in medical school, and then my career in the UK, they've really helped to shape where.
Because I can see that from when you came to do your Masters in Public Health that you'd got into public health very early after graduating, which is actually quite unusual. I mean, certainly in this country, most people seem to, at least in that era, they wandered around and did other things. So I did myself. Spent many years doing other things before I realised that I could make my best contribution through public health. So you attribute at least some of that to your grounding in your medical school in the University of the West Indies.
I definitely think so, Sandra. One of the things that they definitely did in medical school, in my cohort, was that they changed the curriculum because they realized that the vast majority of doctors who they were training in the Caribbean would end up doing primary care, community health, and a very small proportion would end up doing specialist medicine. And so they reoriented the curriculum. So we had much more exposure to public health at every year of our training, in addition to robust clinical training. For some, that was a turn off, but for me, that was fantastic because it meant that very early on, I was doing case control studies. I was involved with outbreak investigations. I was beginning to apply the technical, epidemiological, and statistical skills with my clinical medicine as I was training, because we were developing those skills together.
Yeah, that's very interesting. So then when you came to the UK, was that to do the Masters, or was it because you thought you'd continue here?
No, I knew when I finished medical school that this was my calling. I did well in medical school and got various medals and prizes for OBGYN and for internal medicine. And I remember so clearly when I told my professors that I was going to study public health, they just said, Fenton, what a waste. You should be the next top gynecologist, or you should be the next top internal medicine specialist. But when I explained to them why I was doing this and the passion that I had and the vision that I had, I think they all said, follow your dreams, follow your heart. And if you apply yourself in the same way that you have with these clinical specialties, let's see what happens. And 10 and 20 years later, I'm still in contact with many of those colleagues, and they're like, well done to you, because we remember when you said, this is what you're going to do, and you've done it, and you've really you're trailblazing in so many ways. Yeah. I think those early experiences definitely shaped who I am today, and I'm proud to hold on to them because they're part of my unique story. They're part of the values which I hold today, and they're part of how I see the world, the lens through which I'm able to see the world, and the difference that I bring to the boardroom, the difference that I bring to policy, the difference that I bring to engaging communities. And hopefully you see that as a colleague as well. Yeah. That is part of who I am, and I bring that to the work.
I mean, it's interesting that they were commenting that they thought it'd be a waste of your talent to do something like as expansive as public health. It shows there's a sort of lack of understanding generally, or certainly was in the past in the medical profession, about what public health is and the value that it brings, but also the intellectual capability and rigour that's required to do it effectively.
Correct. Yeah.
Thank you for not becoming an OBGYN.
I know. Can you imagine?
That's an obstetrician and gynecologist for those of you who don't speak American.
I think my time at the London School of Hygiene doing my master's degree really cemented that I was on the right track. Yeah. And because it is one of the top public health institutions in the world, it enabled me to see actually there is a space for this rigor and evidence, and the practice and the discipline of public health isn't a sort of a second order practice within the medical field, that it is a discipline and you can achieve and you can excel in it. And that was really instrumental for me. The London School provided a great grounding, but it also enabled me to build fabulous networks. I still have colleagues from all over the world who I'm still in touch with. And that also helped me to build networks here in the UK, which led to me staying and then continuing my practice here.
Did you, when you came to do the Masters, did you assume you were going to go back to Jamaica and think about what would your public health practice have been like in practical terms if you'd gone back? Because the systems are very different in different countries, and I'm always fascinated by how in some places public health is just something you do alongside clinical medicine, and here it really isn't. So I'd be interested to understand how you managed to navigate that break with seeing patients, which you spend so much of your time and energy developing when you are in medical school.
Yeah. The year in London, which was 92, 93, was really transformational for me, both in terms of me coming to the United Kingdom. I hadn't been back since leaving Glasgow more than 20 years previously. So it was both me as a young man coming to the United Kingdom, understanding the UK, developing professionally. Personally, it was a chance for me also to come out as a gay man, to recognize that part of my being and who I am, and to be okay with understanding that identity, bringing it to my practice, and being my whole self. And that was an important part of, for me, the beginning of my journey on authentic leadership and being able to bring all sides of myself to the table. So the decision to return to the Caribbean was then shaped by all of these life events that I was going through at that time. And then, of course, after a year working here and building those networks, the opportunities began coming. I did go back to clinical medicine after the MPH because I realized that I wanted to do some more clinical work. Having been armed with my MPH, I knew that I was bringing additional capabilities to my clinical practice. I was interested in infectious diseases and HIV, again, linking back to the reason why I became a public health person. And then I decided if I'm going to do work, I'm going to do it in London. I wasn't going to be one of the Caribbean graduates that was going to be shunted off and working in a very small town in the middle of nowhere, because that's the story of so many overseas graduates. I got my first job at UCL, and then that just opened doors. And because I had developed great networks and was beginning to establish myself here, the decision not to go back to the Caribbean was one that wasn't taken lightly, but it was an important one. It was done consciously. And had I returned, I think, that's a great question. I actually, this clinical specialty that I really loved was dermatology.
Oh, really?
So I would have probably continued here to study dermatology at I think it's called the Hospital for Skin Diseases. There's a dermatology institute here. And then I would have gone back and combined dermatology and public health. So that would have been my trajectory.
That is so interesting, because it's not a common combination, dermatology and public health. And it's not something, skin diseases aren't something that we commonly even consider when we're thinking about risks to public health and how to improve people's health, although they're actually already prevalent. So that's interesting that we don't. So maybe there's another thing that you need to start telling us about as a profession.
Maybe. But now that you mention it, maybe there's a theme there about my desire to do the road less traveled. Because there's something about defying expectations. Kevin, you should do this. This is the path that you should be on because you've done this.
So no, I won't.
I'm just like, no. This is what I'm attracted to. This is what I'm passionate.
Because even with the MPH and your interest in the HIV, I'm sure people were trying to encourage you to become an infectious diseases specialist, weren't they?
They were. Tropical medicine, infectious diseases. And that was certainly one of the pathways that I was encouraged to go down. But then I got my first job in public health as a lecturer in epidemiology at UCL. And then that enabled me to then do the sort of postgraduate training in public health. And that opened doors in surveillance and then national public health leadership. There are a few things from my experience from Jamaica that I think really shaped those early years in the UK. One was coming to the UK was a choice, and I wanted it to be a choice. I wasn't here because I was failing somewhere else. I couldn't return to Jamaica. I wanted to be here and I was going to stay here. My decision to go into public health was because I wanted to do it, and I wanted to do it well, and I wanted to train with the best people. And that meant that I probably worked a bit too hard in those early days as a Black young physician coming in a specialty where there weren't many minority candidates. I remember at that time feeling the weight of that as well. To publish a lot, to speak a lot, to develop my craft. I look back now, and those were really fascinating and interesting days. I did so much. But I also understand why I had to do this at that time, because it was about establishing myself here. I had no roots, I had no family. I was here on my own, and I had to make it. And so there's that element of being that migrant physician and the journey that you have to be on in order to establish yourself here.
I mean, you said something really interesting just now. You said, I worked too hard, not very hard. And I'm wondering, where did it took over from very into too hard, and what do you wish you had done as well, where maybe not worked so hard and done something else, taken advantage of something else in London?
Yeah, so I think one of my favorite anecdotes is one of my mentors when I was younger. I was still a lecturer in epidemiology, and I think I had applied for a job and I didn't get it, and I was really disappointed. And my colleague who was senior took me aside and said, Kevin, don't be too hard on yourself. You're going to get to where you want to get to. You absolutely will. And what you need to remember now is that you need to use this time to stop, look around you, smell the roses, appreciate what you have on your journey to where you're going to get to. Because in being so focused on where you're going to get to, you're going to miss a lot of the interesting detours, a lot of the creative things that are going to help you to be a more rounded professional, to be a more rounded person, and to grow in a richer way. And I remember thinking at the time, in classic sort of young man way, oh my God, I can't believe you said that to me. But I did take it to heart. And I think that was such a wonderful transformation point for me, because again, I think with that coming into London and feeling that I had to make it, I wasn't giving myself the grace of understanding and enjoying the experience. And then it happened. I began to let go, began to have more confidence, began to own the space that I was in, and then really began to enjoy both the sort of detours, the fun projects and stuff, as well as being focused on what I wanted to achieve.
And did you really know what you wanted to achieve beyond becoming a public health physician?
I did. You know what I'm like? I could see the people who were in public health who I admired. And when you're a baby public health practitioner, you always think, oh, I want to work at the CDC one day. I'd like to work with WHO one day. And maybe that's part of training in the Caribbean, where you understand global health and those global health agencies. So I was always able to look at that and to see that aspect of who was doing great work in this field, who were the professors who were doing great work. And I could think, what would it take for me to do that and to be there? So that was both an inspiration, it was a challenge, it was an opportunity for me to understand that's where I could be one day. But because of the advice that I got, I was also thinking, let me see what I can do now in terms of interesting projects and stuff, interesting collaborations. So in those early days, did lots of work on community-centered approaches to tackling health, did socio-anthropological research, qualitative studies, in addition to epidemiological studies, was able to do work with local authorities, community organizations, the Department of Health, really diversifying the work that I was doing. And then, interestingly, began to do pieces of work with dermatologists on studies looking at infectious skin diseases and HIV, sexually transmitted infections and stuff. So bringing elements of my passions to the work, which I think allowed me not to be so focused, although I could see where I wanted to get to.
You did get to the CDC.
I did. Yeah.
So what was the thing that enabled that to happen?
Yeah, so it was because I had been doing really interesting work on research on ethnic and racial disparities in HIV and sexually transmitted infections and how they manifested themselves here in the United Kingdom, which was the subject of my PhD. I was collaborating quite a lot with colleagues and in Europe, and ran a number of research networks which connected the continents. And in 2002, my partner at the time got a job in the United States. So he was going to go to the US, and I said, okay, let's go. And I called colleagues at the CDC and said, listen, I'm going to be in the US. It'll be fantastic to be able to work with you in whatever shape or form. And I think because of the relationships I built, they said, listen, why don't you come and join us? We have a vacancy. It'd be lovely to do some work with you on syphilis, which is one of the things I had been doing. And that opened the door to the CDC. I started as the national director for their syphilis elimination program. And then within 6 months of being there, the vacancy to be the national director came up, and I was encouraged to apply and was successful in getting the role. So again, I couldn't have predicted that 2 years earlier, but it was taking the risk picking up the phone, building great networks, and having really good partnerships, which I think has been a constant theme in my career as well.
It's a bit of a story of making your own luck, isn't it? Because, you know, that ringing up and saying, oh, we've got a vacancy sounds like it's just chance, but you'd laid the groundwork with the work you'd been doing and the networks, the relationships you'd been building, which is a sort of recurring theme.
I am actually, as I'm speaking, reflecting on some of those core themes. And it's interesting to see that they still are true today. There's those values, the partnership working, the discipline of being my authentic self and being honest about that, honest in the work and the research that I do are still a feature of who I am today. It doesn't mean I'm not changing, because I am changing. I am evolving as a practitioner. And I'm sure we'll talk about the new things that I'm involved with now. But those foundations are still here.
Was that the pinnacle, being the National Director at the CDC?
I thought it was. And there's something really wonderful about achieving your dreams and then thinking, oh my God, what next? And in a really interesting way, the last decade has been in the what next. Because having done that senior job at the CDC, I thought, okay, I didn't think I would get there that quickly, and I didn't think I would have such a great experience doing that role. And so for the past decade, it's been, well, what is meaningful to me? Where do I want to place my energies? What impact do I want to continue having? And how do I build on all of these experiences to do things which are new and innovative and which align with my values? Coming back from the US to the UK into a role at the Public Health England was an opportunity for me, after 20 years of doing infectious disease epidemiology, to pivot back to general public health. And as you led PHE's non-communicable disease portfolio, which was for some people was an about term, because the natural thing again was, you've done the CDC job, you must go now to WHO and lead the WHO program. And I said, no, I want you to come back to London.
I thought that was one of your ambitions, was to work at WHO. So if they hadn't encouraged you, you'd have gone for it.
Maybe. Maybe. But I wanted to return to London. I had been away for nearly a decade, and London really had become home at that time. And to be honest, I was privileged. I started with the Bush administration. I did the first 4 years of the Obama administration and got to work with President Obama and his team. And knew at that time that it was time to return. Coming back to the UK was a chance to do the what next. What are the new experiences I want to have? How do I bring my learning and my expertise, especially the fantastic CDC experience, to bring that to lead programs in the UK and to encourage us to think differently about public health practice in the UK was completely exciting. So that was part of that journey. And then, as having done 5-6 years at that level, deciding to go back to the front line was also me saying, good, I've done this, what next? How can I be creative? How can I push myself? How can I learn and contribute to new ways? So that's it. I think, and I'm hoping that when people see my career, there is an element of take risks, be creative, build great relationships, and then on the back of that, be able to continue to deliver good work, but also keep pushing yourself, keep learning, because there's so much to do in public health, and it's such an amazing discipline. And too often we pigeonhole ourselves into particular roles, and I think don't fulfill, or full capabilities. And I really am encouraging the people who I mentor to think creatively about their careers and what they do.
Yeah. I can imagine some people saying, but you're quite exceptional, so that might work for you to be taking all these risks and being creative, and that if I don't do the traditional expected thing, it may be negative for my career. What would you say to that?
I would always question the narratives and the stories that we tell ourselves.
Yeah.
And it's very easy for us to tell ourselves who we are and to have oftentimes limiting beliefs. I mean, I have them myself, so I know them only too well.
Yeah.
And that's why I think having mentors, having coaches, having people who can question those self-narratives and help you to challenge them and see them in new ways is so important. There's so many times when I've taught myself out of particular opportunities because I didn't think I was good enough, I was the right candidate, or this was the right time. And it's just that tap on the shoulder of people saying, you are ready, and this is absolutely what you should be doing next. So please put your hat in the ring. So left up to our own devices, I think sometimes that sort of inner saboteur, imposter syndrome, fear of imposter syndrome can sometimes hold us back.
Yeah.
Also, I think a lack of creativity and thinking about how we apply our skills can also affect us as well.
Yeah.
So many times I hear people talking themselves out of, oh, I can't work in the ICB, or I can't work in population health. And you say, but why not?
Yeah.
You have skills that are transferable. Yeah, I don't think there's anything particularly exceptional, but what I have done is benefited from great mentors, people who do challenge me and challenge my own limiting thoughts. And I appreciate that. Both my partner as well as my professional colleagues who are able to say, why are you saying that?
Yeah.
Why are you saying that? Where is that coming from?
I mean, as a coach, I completely agree with all of that. And I've coached people through those self-limiting beliefs and the blockages that they're putting in, or obstacles they're putting in their own way. But for some people, especially people from global majority backgrounds, working in a context like in the UK or the US, some of those obstacles are not their self-limiting beliefs. They're not the things they tell themselves, they're things other people tell them. And it's quite hard to break out of the track that people expect you to be on if you're dealing with all this other stuff as well.
True.
So how did you cope with it?
That's true. I think I coped with it in a couple of ways. I think by doing some of these left turns in my career, the unexpected, it means that you keep people guessing. So they're not able to pigeonhole you entirely. So there's an element of it being intentional and deliberate. And when I have left the UK to go to the US, left the US to come back to the UK, changed my areas of focus and be able to excel in what I'm doing, it has meant, okay, people are seeing not only that are you able to apply your skills in different ways, but you're not being defined necessarily by who they think you are. So that's certainly one way. The second is I'm at the phase in my career where I can choose the collaborations, the projects that I do, and I have a lot of earned autonomy now. I'm seen, I'm trusted, people know who I am, and I can use that in a way that enables me to do things which are not necessarily expected or different or creative, and to bring that to my practice. Now, some of that is because I've been in the system for so long and I'm a known entity, so there's an element of earned trust and building on that. But it's important that for all of us, we don't fall into the trap of believing we are who people think we are, and that we
Or we're only
yes,
what people think we
or
are.
we're only. And that we spend the time to really understand who we are, why we're here, our purpose, the values that underpin us, why we make the decisions we make.
Yeah.
And in that respect, for me, coaching has been such an incredible part of my own professional journey. You mentioned you're a coach. And it's part of self-care for me.
Yeah.
It's part of my professional development. And I'm always the first one to put up my hand when there's a free coaching session available because I'm like, yeah, let me hear what I'm doing next, or what can I unlock next as well.
Yeah, that's really good advice to all the young public health professionals out there. Find a coach. That kind of relates to, it makes me think of your time as president of the faculty and the work that you did as president, which is the faculty is about the professional standards and the training of the specialist profession. But you were also doing some work on trying to diversify the workforce and just make it a more equitable and welcoming place where everyone can flourish. And my experience actually in public health, certainly when I was training, less so these days, but because a bit like you, I've earned myself some autonomy, but there were very rigid expectations of everybody, but then there were some that were very specifically applied to people of particular, usually global majority backgrounds. And it's quite hard when you're in that training space to say, actually, I'm not doing that, or I'm not doing it in that way, because you're trying to meet your goals so you can get out the other side. As a consultant I used to work with years ago, you say, you need to get your ticket. And until you've got your ticket, you don't really have the not just the confidence, but no one takes it seriously.
Correct.
And so, what were some of the things that you were doing during that time?
As president of the
As
faculty.
president, yeah.
The president of the faculty story is a great one, because that's exactly the sort of thing where I would never have considered it, but a colleague tapped me on the shoulder and said, you should really put your hat in the ring for this. I'm like, no, I'm too young. I'm going to wait until later on in my career. I don't think I can bring anything to the job. And they're like, are you kidding me? You know, do this, consider it. And it comes back to your own sort of self-limiting beliefs, or the prism through which you're limiting yourself. And that is why having colleagues who are around you who can say, actually, this might be something you should consider, put your hat in the ring for it. And because the election for the faculty is a national election of all the members of the faculty, you really are putting yourself out there. Vote for me. And yeah, thankfully, the rest is history. I was voted in. And as you can imagine, I was determined, once I understood what the mission was and the job was of the president of the faculty, that I was going to bring my own creative spin to it. And it was just an amazing 3 years. And really, you've asked me earlier about the pinnacles of my career, or the pinnacle of my career. I've had
there may be more than one.
Exactly. I've had pinnacles. And it's been 3 years of both having a day job in London, but having a national profile, national responsibilities. And being able to work with colleagues in all the UK nations, being able to represent my profession, that 30 years earlier, I was justifying why I was going to be doing public health and not obstetrics and gynecology. Being the first Black president of the Faculty of Public Health, being able to not only focus on, and I was very clear about modernizing the faculty, making sure it had a visible presence and voice, strengthening the organization itself because it was in the post-pandemic period, and then reinstilling into our members a sense of pride, of ownership, of excitement about, in a post-pandemic world, what's the role and position of public health, and how do we learn from the pandemic to refresh our specialty and bring new competencies and capabilities to it. So in addition to strengthening the faculty's work on equity, diversity, and inclusion, ensuring that our Black and minority trainees had a better experience, I really developed with the board new working groups, professional groups on AI and public health, racism and public health, equity, diversity, and inclusion, built amazing partnerships with other Royal Colleges, RC Psychiatry, occupational health, GPs. So really position the faculty as a sort of center of excellence for population health and innovative thinking in public health. And then through that, linking with other professions. So it was a really dynamic time, and it was really wonderful to be able to build on the work of other presidents, but then bring my own unique vision and voice to the role. And so that was a real privilege. And I have to say, I miss it, but I don't miss it. I miss it because it was such a privilege to be able to link with our thousands of members. But it's also nice to be at the end of that and to come back to my London role and to be present and to do incredibly exciting work here in London as well. Again, just being present and understanding the opportunities that I had. I never saw myself as being the president of the faculty. Honestly, it just wasn't in my radar. But once it was open and I was encouraged, it said, okay, maybe this is something that I'm being called to do next. Yeah.
It's interesting you remarked about this being this national role and all of the members get to vote, which is true. But you actually had a really national profile, probably an international profile, actually, on the back of your very public presence during the COVID pandemic. And people will remember that there were a number, I mean, Chris Whitty obviously got quite famous and people started recognising him. But there were people who were outside of that national sphere, but very few who did become very prominent, and you were one of them. And I think there are very few public health professionals who've ever had an article about them in GQ magazine. How did that feel?
It felt great. There are many moments where you pick up the phone. My parents were alive at the time, and I'd say, Mom, you wouldn't believe this. Mom, guess what happened? Mom, this has happened today. And my parents were such wonderful supporters. The pandemic, as you said, really allowed public health professionals to really rise up, so whether locally, regionally, or nationally. I started the public health director role for London in March 2020, just before the first national lockdown. And you can imagine having to learn the job at the beginning of a pandemic, work with the mayor, work with the Department of Health, and to land in that role at that time was, I remember thinking to myself, either this is going to make me or it's going to break me, because I don't think anybody would have done that transition. And thankfully, I swam and really was able to, again, use the experiences of the CDC, the national role that I did in Public Health England, and my experience of just having been a director of public health, which meant that I was able to bring that grounding to it, because I had done all these roles, the global, the national, the local, and to bring it to this regional role. And that enabled, I hope, me to not only relate to professionals, but also to the public. And then because of my experience, communication skills, being able to communicate science at a time when there was so much uncertainty and fear, to be able to be a calm and steady voice on it. So in 2020 and 2021, I was in the top 5 top Black Britons. Yeah. In 2020, I think I was between Stormzy and Lewis Hamilton, which got me into the GQ. And in 2021, I was in the top 5, which was wonderful and a real honor, a real honor. And I don't take these things for granted, that there are lots of talented people doing great work. So that ability to have that national profile, but also to be grounded in my own practice and to understand that actually the credibility that I have is predicated on me continuing to do good work, to be a fantastic professional, to be a human person behind the name, has always been a part of what I do. So I've never sought the national spotlight, but if I'm going to do it, I'm going to do it. Yeah. And I'm going to do it based on the credibility that I have.
So has that changed you at all, having that profile? You mentioned when we were chatting earlier that people ask you for selfies all the time.
No, I don't think it does. Because I can't believe people ask for this. I can't believe people. I'm still surprised at how people will see me. And I don't know where that comes from. And maybe that needs more than a coach to really explain why. And it's not an imposter syndrome. It's not a self-doubt. It's just, I still see myself as Kevin. Yeah. I don't see myself as Prof Fenton. I don't see myself as the regional. I don't see myself in that frame of the professional, of the national leader. And maybe if I did, maybe that would unlock even more doors. Who knows? But I'm still me. Yeah. I'm still it's Jenny from the block, equivalent of Kevin Fenton in public health. And that's okay. That's absolutely okay. But it means as and when I need to be in that national persona and I need to be in that national or global presence, I can do it. But I'm safe here and I'm happy here being Kevin. Okay. And that's fine.
Having that national profile and being very recognisable but also followed, I don't mean stalked, means that you've been able to use that with your social media and getting public health messages out really effectively as well.
Yeah. And that's the responsibility of understanding your voice and understanding the unique voice that you have. A lot of colleagues here in the department have said, actually, yourself and the CMO are the 2 most quoted and most visible public health professionals in the country at the moment. And they show the data and our profiles. It's not something I do intentionally, but I have built intentionally my digital and social platforms in addition to my academic publications, because I understand, Sandra, the power of communicating science in an era where trust and misinformation and disinformation is so prevalent. Having trusted voices from a diverse range of backgrounds that can speak honestly and openly and authentically on the issues of the day is priceless. And so I recognize the responsibility that I have with this, and I'm able to use it. So I'm intentional in building my profiles. We were discussing this earlier on Instagram or on LinkedIn, because I understand the power of what I'm doing, and I understand the responsibility of what I'm doing, and to be able to do that well. And so, so that's a key part of my practice as well, that I'm doing good work, but I'm also telling you that I'm doing good work in partnership with others, and I'm telling you about the impact that we're having and why this is important. So that's part of what I do in terms of...
So in telling people about the good work, are you trying to inspire other public health professionals, or are you trying to communicate about public health to the public?
All of the above.
Okay.
All of the above. Because for every experience, there are different stories that I can tell. The story of my work on HIV in London, I'm privileged to chair the Fast Track City's HIV prevention program for the city, is a story of London's triumph over an epidemic that has affects 100,000 people in this country. London was the epicenter of the epidemic in the UK. And we're now leading globally on reducing new HIV infections. We have the highest levels of antiretroviral coverage and suppression in any global city in the world, and we're an exemplar of the work we do. That story is a story of public health leadership and triumph. It's a story of scientific developments and impact that it has. But it's also a human story of advocacy, of overcoming stigma and discrimination. And at the core of it, it's a story of how communities and the voice of communities have been able to change national policy over many decades. In any given frame, I can tell the science, I can tell the public health, but I can also tell the human story.
Yeah.
And the ability to bring that together, I think, is key. So depending on who I'm speaking to, what needs to be done, what needs to be said, to be able to pull on those narratives and to tell those stories in a compelling and open way, I think is an important skill that I've developed over the years.
Yeah. But just to take you right back to the beginning of your public health career, nearly to the beginning when you were doing your PhD, was about ethnic inequalities in HIV infections. And this programme is about tackling racism and inequalities more generally, and thinking and trying to work through the different practical ways that we need to change our public health practice, and that we need to advocate for others to change the policies and the way that they practice and change systems and structures. So we've come full circle in a way. You started there and we're there now. What do you see has changed over that 30 years, and what do you think we need to be doing now?
Yeah, so much has changed. When I started to do work on racial and ethnic disparities in STIs, my mission was to move from simply describing the differences, because a lot of the science at the time was stuck in describing the differences between Black, white, Asian, and other. And I said, this is not good enough, because we need to understand why these differences occur, and more importantly, what are we going to do about them? So a lot of my early research was bringing socio-anthropological work with the epidemiology to explain the context of what was happening, and then to link that to policy recommendations. And then in my role as a public health practitioner, to be able to work with local authorities, work with the Department of Health to develop policies. So that entire cycle of understanding, going deeper, challenging, and then coming out with recommendations and implement has been a part of my practice. It's changed over time in three ways. One, there are many more researchers now of many more diverse backgrounds doing this work. And I feel proud that people are still quoting my papers from 1992, my work from 1999, because they were opening the doors for what was to come. So the nature and range of the researchers and the science being done in the field has improved, has changed, is more diverse, and is wonderful to see. Second, I think, at the time that I was doing it, there was such fear about describing what really drove these epidemics in an honest way. You couldn't mention this ethnic group because you'd be stigmatizing this group. And I'd say, but actually you need to tell people that this is what's happening, so people are informed and empowered to change or to act on it. You can't hold this information back because you're afraid of being seen as stigmatizing or racist. And here's how you do it. So I think the second thing that has changed is the willingness for the health and care system to be able to talk about these differences and to understand what we need to do. And the third thing that has changed is a real understanding that these differences are not located solely in differences in behavior. In fact, for the majority of the time, it's not as a result of individual behaviors, but even the safest behaviors in a prevalence of infection, which is high because they have poor services, poor diagnostic access, means that you could have one sexual partner, but you're still at risk of acquiring HIV. low-risk behaviors in a context where people have poor experiences of accessing services or being treated well in services means that even that one person living with a condition will not benefit from the health and care service. So the third thing that has changed is understanding that the patterns of disease that we see are a dynamic interaction between the individual, the healthcare system, and the policies around it. And there's more responsibility on the policy and the system side rather than on the individual.
Yeah.
A lot of that early work was centered on individual determinants, and now we're being able to look more broadly. And part of that is the honesty of talking about structural discrimination and racism, which again, we may take for granted today, but prior to the pandemic, certainly in the noughties, it wasn't part of the lexicon in terms of what public health did and how we spoke. So that's also been a huge change as well.
Yeah, I've noticed people used to talk about cultural competency while still talking about ethnic or racial differences, attributing them to culture and saying, so therefore we have to be culturally competent in the way we deal with it, to now understanding that actually there are a lot of things that are driving health outcomes and that individual responsibility plays a very small part relative to the bigger picture. So we have come a long way. Where do you think we need to be going next?
So I think the wins that we've had in terms of the advances remain fragile. And I think what we've seen in the United States, where within 18 months, much of what we thought were now a given and an established part of our practice has been rolled back. And I think there's a real lesson there that we should never take for granted what we have achieved, and that to secure continued progress in these issues requires us to work proactively and agilely every day. And we see it here in the UK as well, and especially in England, as we go through another transformation of the health and care system, more focus on productivity, more focus on, in a sense, driving the widgets and moving away from the humanity of the services, that there's a real risk that we'll say, actually, equity, diversity, and inclusion, there's no evidence to support it, and we're going to roll it back, etc. It's very easy to see a future in which many of these, the things that we now hold true, can be rolled back. On one hand, I would like to think that the trajectory of what we've done means that we'll now develop much more robust programs to tackle structural racism and discrimination, that we will develop more robust metrics to measure how these programs are being developed and delivered and programmed in our health system, that we'll begin to develop communities of practice and to think about really centering communities' experiences in how we design services. But on the other hand, I also have to keep an eye on what might happen from left field to secure these gains. And maybe that's why, as on social media, I'm doing a lot more now on talking about public health, talking about these issues, ensuring that people understand the value add that we provide and why we need to secure and cherish this, that the clean air that we breathe, the clean water that we depend on, the lack of infectious disease outbreaks from childhood infections that we had benefited from for many years didn't just appear overnight because of the investments that we've had in public health for many decades. So there's a part of me that, for this agenda, wants to secure that while we think about the future as well.
There's still a tendency among some people, and in particular, in my experience, politicians, to think that public health is about campaigns, without necessarily understanding the kind of all of that underpinning scientific, intellectual rigor, evidence base that we draw on. And it'd be quite easy, even for politicians who are quite willing to say, we just need a campaign, rather than, but we don't need all those people, all these expensive people doing all that work. And I know that's a bit of a challenge in some local authorities at the moment, and maybe more of a challenge for more of us after the upcoming elections. And I'm in a politically restricted post. I'm imagining that yours is too. So we can't say anything about the party politics of it. I'd just like to get your take on how we navigate that political environment where we have to influence politicians, and they come at it with often very limited understanding of what public health practice really is, but also with their political views about how things should be done in the world.
And this is where I think there's a humility that I think we need to bring as public health practitioners, because not everybody knows who you are, what you do, and why you do it. And what I've learned whether working with the Republican Bush administration or the Obama administration, whether working with Boris Johnson and the Conservatives or working with Keir Starmer and Labour Party. Part of what we do in public health is having to work with politicians. It's part of the day job. So we have a responsibility not to influence, but to advise. And with all of the political colleagues I work on, it is my responsibility to be able to explain clearly about what we do, that it's more than campaigns, and that the perspectives that we bring of evidence, the focus on equity, helping to deliver in complexity, helping to bring systems together, helping them to understand how we capture and understand the voice of communities in a more robust way. Very quickly, I found, when I've spent time with local councillors, MPs, secretaries of state, they begin to see the value, they begin to see the richness that we can bring. And that's really important. So understanding the core skills that we have and how we bring is important, but being able to advise and educate and bring colleagues along will be equally important. I never take for granted that people understand what I do. I don't even think my partner understands truly what I do. So it's my responsibility to be able to say, here's how my work has made a difference in your life today, and this is what you can do to help. And what I have seen is that the humility of also understanding what the politicians want to achieve, and then being able to say, okay, I can use my skills to help you to achieve that. And here's how we would do it, and do it in a way that is robust, a way that is acceptable, grounded in the science and evidence. Or if it's something that can't be achieved or shouldn't be achieved because it could cause harm, to be able to say, I know what you're trying to achieve. However, this is what the evidence says. Have you thought of doing it in this way? Can we go away and think about a way in which we can help you to achieve that? Most politicians want to do things that will improve the lives and well-being of the communities that they're serving. So that brings public health and politics together in a really lovely way, because there's a common element there. We may have different paradigms through which we see the world, but ultimately we can find that win-win. And that's where trust is built, and that's where confidence is built, and that's where a more mature relationship is also built as well. Finding those common threads and building from them.
Yeah, I agree. I mean, I haven't had quite the experience, I haven't had the international experience that you've had, but I've definitely worked in local authorities with different political complexions. And I can always find a way to work with politicians, because we might not have the same idea at the beginning about how to do something, but we usually have the same idea about wanting to improve things for people.
That's right.
Yeah. Going back to your ambitions when you were a young public health practitioner and thinking about where do you want to get to, and you made it to the CDC, haven't made it to WHO yet. You've got this amazing job at the moment, but what's next for Professor Kevin Fenton, CBE?
Yeah, I don't know, but I know. And I'm holding those two things simultaneously. I know because I believe I know what I'm being called to do next, which is completing this arc, which is my life of service. And as we've discussed today, that service is manifesting itself in different ways. National leadership, global leadership, creativity and my ability to bring different portfolios together, but also always in the service of communities and improving health and tackling inequalities. So that arc of leadership will be, in a sense, my life purpose and what I'm going to be doing next. So I know that whatever I do next will be on that arc, and it will be a development of that. Specific ways in which it's going to manifest itself, I don't know. And Sandra, I'm happy that I don't know, because it forces me to be present and to not worry about the future. And if there's one element of growth that I've come into, is really enjoying the moment, And that's why my colleague who mentored me way back in the day, I wish I could see him today to say to him, thank you so much, because your words literally changed my life. So there's a joy that I have now in focusing on what I'm doing, and to see all the offers that keep coming in. Kevin, can you do this? Will you do this? Etc. And to be able to say no, and here's the reason why I'm saying no, or to be able to say yes. And I want to be able to enjoy this side, being the public health director for the largest city in Western Europe and to be the global director for London, the public health director for London, the global city, is an amazing opportunity. Let me just enjoy this for as long as I have it, and let's see what comes next. But if my past is any prediction of the future, I can guarantee three things. It's going to be left field, something that you didn't expect. It's going to be something that, when you look at what I've done, makes sense. And it's something that's going to be building on everything that I've done so far.
And if we want you to do it, we tell you that you can't.
Yes. That's true.
Okay, I really don't think you should be Chief Medical Officer.
Not going to do it.
Okay. Was there anything that you wanted to cover that we didn't?
No, I just want to say thank you. And it's been so wonderful to have the time to reflect and to tell my story. Because I still see myself as Kevin from the block, it's sometimes interesting to me that people want to hear the story and want to explore why I'm here today and what I'm doing. And I thank you for the space to do that. And even in telling the story, I've had my own insights today. So I think I want to sit with that for a little bit because that's been really a gift. So thank you.
Thank you. Thank you very much, Professor Kevin Fenton. Thank you so much.